Okay, so we have a medium difficulty question for renal path. I will tell you exactly what we need to know, not waste our fucking time. Some high yield points I'm going to make, even if you already think you know the answer. So before we get started, please subscribe my channel. I really appreciate it. Give the video a like, really appreciate it. And find me on Instagram at Mehlman_medical, MEHL_medical. Link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now let's start the fucking question here, where we've got 42-year-old dude, type 1 diabetes, hypertension, 2-week history of fatigue and puffiness of his hands and face, sore throat 2 weeks ago that resolved yesterday. BMI is 38, physical exam shows periorbital and pedal edema, urine studies show 2+ protein and no blood, a renal biopsy is shown. This image, very easy pass-level spot diagnosis for diabetic glomerulosclerosis. These pink circles are chymosteel-Wilson nodules. They are due to hyaline deposition. I will explain our answers in a moment because hyaline deposition is the wrong fucking answer, okay? Now, if we ignore this image and we just look at the vignette, I mean, to have some sort of upper respiratory tract viral infection plus edema where we have no blood in the urine, just protein, that sounds like minimal change disease, okay? I mean, although minimal change disease is rare in adults, so we wouldn't really be thinking that here. It's not that it's impossible, it's just minimal change disease tends to be pediatrics, okay, where you have nephrotic syndrome. But this no blood in the urine, really important detail because that's going to help us sift through potential differentials. So let's just walk through the answers here as far as why this guy might have edema. And we can try to eliminate and sort out what's going on. So choice A, C3 and IgG deposition, wrong fucking answer because this refers to PSGN, post-streptococcal glomerulonephritis. I mean, the fact that he has no blood in the urine, we can immediately eliminate that. I mean, that's important. So PSGN is going to be sore throat due to strep pyogeny, strep pharyngitis. It can also be due to skin infections, by the way, okay? Cellulitis, impetigo, erysipelas, but it's going to be sore throat followed by red urine 1 to 3 weeks later, or impetigo followed by red urine 7 days later after start of the lesions, okay? That's C3 and IgG deposition. There will be blood in the urine for PSGN, as I said. Choice B, hyaline deposition, wrong fucking answer. It's because although, yes, we have chymosteel-Wilson nodules, and although, yes, they are hyaline, it's the hyaline deposition in and of itself is not the etiology for edema in diabetic glomerulosclerosis, okay? So let's just keep going through the answer choices here. Choice C, IgA deposition, wrong fucking answer. I mean, this refers to IgA nephropathy, okay? And you would get blood in the urine with IgA nephropathy. It would be an upper respiratory tract viral infection. Can rarely be GI, but usually a viral URTI plus red urine 1 to 3 days later, okay? It can also be part of Henoch-Schönlein purpura in pediatrics, which is IgA nephropathy. Viral infection causing IgA nephropathy can cause palpable purpura, arthritis, and abdominal pain. So IgA deposition, wrong fucking answer. Choice D, thickening of the basement membrane is our correct answer. I mean, in diabetic glomerulosclerosis, we have non-enzymatic glycosylation of the glomerular basement membrane, causes thickening, loss of size and charge barrier. So although this guy's edema is acute, and we want to speculate as far as could this be minimal change disease, none of these answers even apply to minimal change disease. None of them do. Okay, I mean, we'd have loss of size and charge barrier, and choice D would still be the best answer, even if we thought the answer is just purely minimal change disease. So non-enzymatic glycosylation of the glomerular basement membrane is the first histologic change we see in diabetes under electron microscopy. The first change, however, that we don't see anything histologically in diabetes is actually hyperfiltration. That's important. So increased GFR. They do ask that on NBME exam. You have more glucose flying through Bowman capsule, it's going to pull water with it. So we actually get hyperfiltration, increased GFR acutely. So thickening of the basement membrane, very important you know this detail for diabetic glomerulosclerosis. Choice E, thinning and splitting of the basement membrane, wrong fucking answer. This refers to Alport syndrome, X-linked recessive condition where it's going to be a dude, generally 28 years old, where he has an ear or an eye problem plus hematuria. Okay, so it's mutation in type 4 collagen. Easy to confuse that with Goodpasture syndrome. Totally separate fucking discussion. Okay, it's antibodies against type 4 collagen. And that would be a dude 20s to 40s who has hematuria and hemoptysis, okay, and linear immunofluorescence on renal biopsy. So look, we could make this an extended clip, but what I want you to take home is that non-enzymatic glycosylation of the glomerular basement membrane, thickening of the basement membrane, this is important in diabetic glomerulosclerosis, and that we have chymosteel-Wilson nodules, the spot image here. I mean, you have to know this. You know the deal. I'm going to continue making more content. If you like my stuff, subscribe to my channel, and I appreciate your time. That's it.